patient satisfaction post knee replacement surgery. Now, for us, a definition of a successful TKR is definitely a good looking X-ray. But what probably matters more is a happy patient. Why is that? A happy patient is going to bring us more patients and more reputation in our community as compared to a good looking X-ray. So there is no doubt that a successful TKR is equivalent to a happy patient. Now, there's a lot of literature, despite so many good cases, there's a lot of literature on patient being dissatisfied after knee replacement surgery. Now, these are all flawless knees in which the X-ray looks perfectly normal, but still about 8 to 25%, on an average, about 20% of the patients, which is 1 in 5 patients, are dissatisfied after their knee replacement surgery. Now, do we tell each of our potential knee replacement patient that, look, there is 1 in 5 chance that you're not going to be happy with the knee that I'm going to do? Obviously, the answer is no. That's not what we put forward to the patient. But is there a way around? The answer to this is knowing our patient expectations before the surgery and trying to manage or trying to fulfill those particular expectations. So it is that 1 minute of consultation time where you actually sit down and ask your patient that, okay, what exactly do you want from me or from the surgery? And when they tell you this, and that is what you are able to document and attain after the surgery, which I think is important in attaining your patient satisfaction. There are various variables for dissatisfaction. Why could the patient be unhappy despite the normal looking or well done knee replacement surgery? Are these. So there are some knee factors which include pain in the knee joint, stiffness of your joint, less function as compared to expectation, and repeated inflammation where the patient may have swelling, redness, warmth without an infection. There are some patient factors which are responsible for dissatisfaction, which may be the mental being and the physical being of the patient, which is the health of the patient, and the quality of life that the patient is undergoing at that point in time. As I already discussed, pre-surgery expectation is the key variable for patient dissatisfaction or satisfaction, and any unexpected thing happening if you have not explained a particular complication. And if that happens, then that may be one of the setting things for dissatisfaction after the surgery. Of course, dissatisfaction varies between various demographics, age, gender, and employment status. Let's talk about the main kid on the block, which is the pain. And any painful knee is an unhappy knee. This is a key factor for dissatisfaction. We all have our various tools to ascertain the dissatisfaction. Visual analog scale, when you assess the patient first time in the clinic and after the surgery and then months after the surgery, I think is a very useful tool where you can objectively know how the pain is. The very important tool which I find in the practice is the Likert tool. Now, this is a tool which you see on the screen, and you may have seen it outside the malls, outside even the toilets in the malls, where whether you're very satisfied, happy, unhappy, and very unhappy with the service that is there or with the cleanliness. So similarly, for pain or for satisfaction after the knee replacement surgery, for those who do not want to get into the proms and the scores and all of those things, I think this one simple tool, Likert tool, will give you a lot of insight upon how you're doing this. And this is a well-validated tool where there's n number of surgeries, where n number of studies where this longitudinal observation of this particular tool in our patients will give you a good feedback of how your practice is going. It is important that the patient does not remember the pain after the surgery for lifetime. Many of them may have bad experience immediately after the surgery where they had such a bad pain that they never come back for the second knee. So it is very important that as arthroplasty surgeons, we manage our perioperative pain very aggressively without causing side effects. We also need to look into some patient who may have chronic pains after the surgery, which may last for months or years, and how you involve all the drugs which are nerve medications, or how do you involve the pain specialist, again, is key factor. So this one particular slide is the main takeaway from this, that if you are able to manage the pain after the surgery, this is going to be the happy patient. Other important thing which the literature mentions is selecting the right patient, and we all know what a right patient means. So first and foremost, the patient should have no mental health issues in the form of depression, anxiety. There should be good amount of grade 4 osteoarthritic changes on the X-ray. Early arthritis patient with a knee replacement is going to be a nightmare. The patient does not have a referred knee pain with the low backache. And of course, the BMI is important to avoid post-op complications. We could debate with regards to patella resurfacing and mobile insert, but it has been found in literature that with these patients have got higher level of satisfaction after the surgery. But of course, it is a matter of debate. Scores, and everyone thinks that patient satisfaction ko janna hai, yani we need to know what scores and how it is doing and all those things. So why are scores into so much into the limelight? The reason is one particular day in NHS where it was declared that we need to ration our joint replacement on the basis of the Oxford hip and knee scores, which means that the one which the patient with having a bad score will be prioritized to do a joint replacement surgery as compared to the other. So that's when everyone started talking about the scores, and these are basically the proms and scores which are very much there. And we have the SF36 WOMAC Knee Society score. COOS is only for injury or post-injury after the knee at the knee joint, may or may not be related to arthroplasty. Oxford knee score and the forgotten joint score. So let's have a snapshot of each of these. These are based on two concepts. Number one, some of these scores are entirely patient reported. Where patient has a questionnaire, they will fill it and we will score it, where there is no active involvement of a clinician. The other one is somewhere documented by the healthcare professional with the involvement of the patient, where you can objectively document things. Now, each of them have got advantages and disadvantages. The advantage of the patient reported score is that it is very pure and generic, where there is no bias that can come from the treating doctor. It will be entirely patient based. The disadvantage of patient reported is that different patients may feel differently about the same thing. So there may be a lot of variations in what patients report based on what they're feeling at that point in time. The advantage of documentation by healthcare professional is that you may have those parameters which cannot be measured by the patient, like an extension lag or the knee range of motion, which are important. And these are beyond the X-ray. These are something which cannot be seen on the X-ray, but which can be documented by us and which are important in our clinical practice. Of course, we spoke about the disadvantage of having a bias, that this knee replacement has been done by me. So we may underrate what the patient feels. So this is what a typical knee society score looks like. You may remember filling all these forms in the past, where before the surgery, after the surgery, at regular intervals, you do all the paperwork. Of course, what I recommend these days is that if I use knee society score, and I find this Ortho toolkit very useful. Number one, it is completely online, so no paperwork. Number two, you can train your staff. So you don't have to do it all. You can really train your staff to use this. It is easy, gives instant result. So you can just document the final score based on this Ortho toolkit. Talking about the WOMAC score, WOMAC is the most extensively used score in literature, not just for knee replacement, but even for hip osteoarthritis. And this is one of the most famous scores, to be honest. This is very specific for the joint. This is based on pain, stiffness, and physical function. This is entirely patient-based. So there is no involvement of the physician or the treating doctor. And the patient fills this, and we can have the final score. The advantage is that it is pertaining to the joint, not generally for the entire patient. There are some issues with the subscales. There are three different subscales in this. So the reporting in subscales may be a little bit different. So they may not be comparable with each other. But it is very good for before after. So if you have taken a WOMAC scale before and then you're taking the WOMAC scale after, the comparison has got a lot of value as compared to just one particular scale. SF36 is again a widely used score, and we have SF12, SF36, and these are more to do with the general health. This is not joint specific or knee replacement specific. You may make it specific, but in general, the whole idea was to have the holistic approach towards a patient, where the physical and the mental well being of the patient is equally important. It is one of the famous tools among the physiotherapists. So, if it is your physiotherapist who is doing all the scoring, she may like to use this particular score. It is considered to be in isolation, it is considered to be bad for just an individual comparison, which means that if you want to know whether your knee replacements are good in general for the entire population, yes, it's a very good score tool. But if you just want to measure for one particular patient, this may not be so very useful in isolation or by itself. So, what is the recommendation? There is no one single tool which is really recommended. But what is recommended is that you have one general score, which talks about the entire patient, and one joint specific score, which is to do with the arthritis, which is to do with the knee replacement. So, for example, you may use a combination of an SF36 with a WOMAC, which is SF36 is a general tool and WOMAC is an entirely patient based tool. Or if you want to objectively involve yourself, then it is SF36 plus OKS, where the patient can fill the where the clinician can fill the OKS part of it, and SF36 will be the general tool. Let's also talk about the forgotten joint score. And there's a lot talk about the forgotten joint these days. The original terms comes with the hip replacement surgery, where the patient has forgotten that he had a hip replacement done. But to have it with the knee replacement can sometimes be challenging. We all want our knee replacements patients to forget that they had a knee replacement done. And this is typically not in weeks or months, but probably years after the surgery. What is important is that there is only one question which is asked: that are you aware of your artificial knee at various places, like bed at night, or while traveling in the car, or while you're climbing your stairs, or while you're going on a walk? So there's one question: that do you remember your artificial knee, or you just forget about it while you do these activities? So one important point about FJS is that if you have a set of patients who are doing very good, and you want to know that these good patients are just good, or they are very good, or they are very, very good, then this is a very useful tool. But if you want to compare a patient who is neutrally satisfied, or who finds your joint okayish or not so very satisfied, and you are comparing it to a satisfied patient, this is not a very good tool. So to subclassify your good patients, the forgotten joint score is very, very good. Why is that? Because the ceiling effect is low. What is ceiling effect? So whenever, suppose this is the highest level of satisfaction that you can attain with your joint replacement surgery. Ceiling effect means that whenever your reading is within 15% of the highest. So when your reading is within 15% of the highest, that is called as a ceiling effect. So the forgotten joint score does not reach the ceiling very early. So the good patients you are able to classify very well. Not everyone will be classified into the best category. You may be able to sub-classify into good, very good, and very, very good with the help of FJS. It is important that you use the FJS tool before and after, and that after has to be at least 1 year after the surgery. Then it makes more sense. Now, can you predict whether the patient is going to be dissatisfied? There is a good article in JOA, this one, which I put up on the screen, where if you don't just rely on the patient-reported outcomes, but if you also use an objective score like OKS and PAS and all these things, and you can predict as early as 6 weeks whether this patient is going to be dissatisfied in the longer run. So this one particular article I would recommend if you want to predict early your dissatisfied patient. Now, we all talk about patient expectation. At the start of the talk, I told that the patient expectation needs to be managed. So what expectation does your patient have, and how do you document this? So HSS Hospital for Special Surgery has given us a very useful, no, I would not call it a tool, but a survey, where these were the various factors that they study, and these were the questions that were put, and each question had their own importance. So like relief of pain is more important as compared to be employed. So every question or every expectation is rated as to importance, and it has been rated as 0, 1, 2, 3, 4. And it has been graded like that, that some expectations are more important to the patient as compared to the others. And this is a very nice survey that was done by the HSS. Another important thing is that my society score has improved from 10 to 20 or from 10 to 12. Is it really a worthwhile thing? So remember that statistically significant improvement does not mean clinically significant improvement. You may have statistical significance, which suggests that, okay, this change is not by chance, but with your joint itself, or with your surgery itself, or with your rehab itself. But this does not completely translate that the patient will feel clinically better. And what can you do to know whether change in the score can make the clinical difference is this particular article. And this is very, very important concept in patient satisfaction, where what is the minimum important change in a particular score which will be clinically relevant. So this article will tell you that with each score, whether it's Oxford knee score, how much should be the change, with KSS, how much should be the change, FJS, how much should be the change. One thing worth mentioning is the translation and validation. We all can make our own scores today. No, I don't like this question, I'll put this particular question. Can you use that score? No, it has to be validated. Secondly, a tool in one country may not be valid for the other. So there are different countries like Finland and Sweden and Thailand and China. All they have done is they have translated the respective scores in their own national or mother language and then got them validated. So I'm not sure if we have one in India as yet, but this is very, very important that we have a locally available score and it is translated in the easy to understand language, because not all our patients may understand the English language, and it is validated by the authorities that, okay, this particular score can be used with the help of data. One thing worth mentioning is the importance of psychological stress. And we did touch upon that, anxiety patients, depression patients are not so very good candidates for TKR. But this is a new concept which I'm introducing in my talk today, which is given in the literature now, is can we do anything for this, or we just don't operate? And what about those patients who have operated and now haven't, now you know that they have episodes of anxiety, depression, and so on. So there was this good concept introduced in this particular article, and everybody would benefit by reading this particular article, which is full glass, glass half full, and glass half empty concept. Glass full is basically a patient who is completely satisfied. Glass half empty is a patient who is not so very satisfied. And glass half full is partially satisfied patients. So we have divided patients into these three particular categories. And now we want to change the level of satisfaction of the patient. Are we able to do that? You have already operated. Now, how will you change the satisfaction? It is possible with the help of psychology. The principle is recalibrate, reframe, and reconceptualize. What does recalibrate mean? That you or the psychologist introduces this concept where the patient wants to recalibrate between what level of pain they had before the surgery and what level of pain they have now. So they may become more realistic whether they are truly satisfied or not. They may just say that I'm not satisfied, but when you truly ask them, ki utna hi dukta hai kya? They may say, nahi, utna hi nahi dukta hai. Secondly, in recalibrate, comparison with self is important, and they may compare with others. That Mr. Patil is not able to walk even 5 steps. See, I'm walking 10 steps. So comparison to self and comparison to others is one of the methodology where the patient can improve the level of satisfaction. That is recalibration. What is reframing valued activities? Reframing means that they expected that they will be able to play basketball after doing the knee replacement surgery. Unfortunately, despite your best efforts, the patient was not able to play basketball. But instead of basketball, he is not now playing cricket, or maybe he's playing table tennis. So he has reframed the activity, he has changed the activity, and now he values the new activity more. So by changing the activity, he is still being active, and he has started giving more importance to the new activity as compared to the old activity. And this seems to be improving the satisfaction of the patient. And the last thing is reconceptualize, where not much seems to have improved, but the patient says that, okay, I'm much older now as compared to when I was young. So obviously, I will not be able to do those things. And he is ascertaining the dissatisfaction not to your knee replacement surgery, but to his circumstances, to his age, or to some other XYZ. So that is called as reconceptualizing. So this is a very new concept, and I think as joint replacement surgeons, to have more satisfied patients and how to deal with unsatisfied patients, this is one thing which we can look into. When do you call it a day? That okay, in 6 months' time, if the patient comes to me and tells me I'm not happy with the knee replacement, do you classify this as a dissatisfied patient forever? The answer is no. Lot of literature mentions 1 year, that at 1 year, if the patient is not happy, is not going to be happy. But truly speaking, if you look at the meta-analysis and this particular literature, you'll find 4 years. So even if your patient is unhappy at 1 year, you have a margin up to 4 years to make this patient into satisfaction with the help of whatever technique you want to use. But 4 years is the actual cutoff after which the patient state changing is going to be very, very difficult. So to summarize, patient happiness is equivalent to patient expectation being fulfilled. No one score is perfect, but consistency of using the same score in your practice is going to be very important. Typically, combination of two scores. Psychiatric illness history is vital, and please look into whether your patient has got depression issues, anxiety issues. These are going to be the patients who are going to be unhappy. Have a protocol in place where you document what approach you want to use for knowing your outcomes, whether it is just a normal Likert scale of satisfied, dissatisfied, very dissatisfied, or whether you want to use a scoring system. And that is going to be very good, very important for knowing whether our patients are going satisfied or unsatisfied in the longer run. Thank you very much.